Welcome to the second English webinar of International League Against Epilepsy, East Mediterranean region. Today we have the honor and the privilege of having two eminent speakers, Professor Emilio Perucca and Professor Hassan Husni. Professor Emilio Perucca will present the first session and will talk about new anti-seizures drugs. Then the second session will follow with Professor Hassan Husni, who will talk about epilepsy in elderly. As usual, after each session, the speaker will answer your question. Now, before starting the first session, I would like to introduce Professor Emilio Perucca. He trained as neurologist and clinical pharmacologist at the National Hospital for Nervous Diseases, London. He is currently past president of the International League Against Epilepsy, professor at the University of Pavia, director of the Clinical Trial Center of the Department of Neuroscience in Melbourne, Australia. He received the International League Against Epilepsy and International Bureau for Epilepsy Ambassador for Epilepsy Award in 1997, and International League Against Epilepsy European Epileptology Award in 2018. His main research interest in the drug treatment of epilepsy. He authored over 500 public listed publications with an each index of 80 and citation index of 25,000. You have the floor, Professor Perucca.
Dear colleagues and friends, welcome to the ILAE Eastern Mediterranean webinar. It's a great pleasure to be with you tonight and discuss together the new anti-seizure medications. And I'm pointing out that we are using the term anti-seizure, not anti-epileptic, to emphasize the fact that the drugs that we currently use to treat epilepsy are efficacious to control the symptom, the seizures, but have no effect on the underlying disease. You have here my disclosure. And what you see next is a disclaimer, meaning that what I will be discussing is my interpretation of the evidence. My views do not necessarily reflect the views of the ILAE or regulators, and I invite you to check prescribing information in the countries where you practice. So let's move into the topic, and what you find in this slide is a list of currently available medications to treat epilepsy, and the new medications that we will be discussing today are those marked in red in this slide. And the reason we are calling them new is because they came in after a 20 years interval since the introduction of valproate in '67. However, many of these drugs are actually not new at all. They've been around for about 30 years. And therefore, it's not appropriate to call them new. It's more appropriate to call them, and this is what we'll be doing for the rest of my talk tonight, second generation drugs, as opposed to the first generation compounds, which are those shown in black in this slide. I will divide my presentation into different sections, discussing first key properties of these drugs, then address their overall impact on seizure and safety outcomes, briefly discuss their role in current treatment, and then close mentioning drugs in clinical development and some future perspectives. And when discussing key properties and dealing with anti-seizure drugs, one of the key properties to be discussed is the efficacy spectrum, meaning against which seizure types a specific drug is effective against. And this slide is a little bit an oversimplification, and I have divided drugs into 3 different groups, starting on the right, drugs for absence seizures. Ethosuximide is there, Ethosuximide might have some efficacy also against myoclonic seizures, but overall has no efficacy against other seizure types. Then we have in the center what they call drugs active on focal seizures, and by focal, of course, I mean focal plus focal to bilateral tonic-clonic, which is the modern term we are using to define what used to be called as secondary generalized tonic-clonic seizures. And the reason for placing these drugs in this column is that evidence for efficacy for these compounds is mostly restricted to focal epilepsies. Admittedly, for carbamazepine, phenytoin, or scarbazepine, esricarbazepine, there is some evidence that they can work also against, be effective also against generalized tonic-clonic seizures. But many of these drugs, including those that I have mentioned, have the potential to precipitate or aggravate myoclonic and absence seizures in patients with generalized epilepsies or combined focal and generalized epilepsy. I placed a question mark for brivaracetam because its mode of action is very similar to that of levetiracetam, and we expect it to have a similar efficacy spectrum, whether for the time being the studies on brivaracetam have been mostly conducted in patients with focal epilepsy. And then we have on the left what they call the fully or partly broad spectrum drugs, meaning that they all work against focal seizures and one or more generalized seizure types. Although it's only valproate and benzodiazepines that are entirely fully broad spectrum. They work against all seizure types. The other drugs are not as broad spectrum. For example, phenobarbital and primidone are not efficacious against absence. Levetiracetam is efficacious against focal, generalized tonic-clonic, myoclonic. It's probably a weak drug for absence seizures, and there is no good evidence of levetiracetam being efficacious against tonic, tonic, and drop attack seizures. Lamotrigine is relatively broad spectrum, but there is evidence that, at least in some patients, it may aggravate myoclonic seizures, and definitely is contraindicated as it can aggravate in general seizures associated with Dravet syndrome. Topiramate, also relatively broad spectrum, although we don't have much evidence of topiramate being efficacious against absence seizures. Zonisamide, broad spectrum as well, with some reports in particular mentioning good efficacy in myoclonic seizures, particularly those associated with progressive myoclonic epilepsies. And perampanel and lacosamide are kind of newcomers, and the best evidence for efficacy for these two drugs is for focal seizures and generalized tonic-clonic seizures. You may have noticed that some drugs are missing from this slide, and this is because I left some drugs, and they are here, into a separate category, because I call them syndrome-specific, because their use is reserved to patients with certain syndromes. Cannabidiol, which has been approved in Europe, in the US, and other countries lately, is efficacious in seizures associated with Lennox-Gastaut syndrome, Dravet syndrome, and tuberous sclerosis complex. Felbamate and rufinamide have been around for some time for Lennox-Gastaut. And by the way, there are other drugs which are efficacious against drop attacks in Lennox-Gastaut, for example, valproate, clobazam, topiramate, lamotrigine, of course. Then we have two more drugs which are specific for Dravet in addition to cannabidiol, and they are fenfluramine and stiripentol. Everolimus is approved for seizures associated with tuberous sclerosis complex, and I'm sure you are aware that vigabatrin is mainly used these days for the treatment of infantile spasms. It is also efficacious against focal seizures, but is very rarely used as a drug for focal seizures because of its serious toxicity, irreversible restriction of the visual field. When it comes to magnitude of efficacy, let's discuss that briefly. A number of drugs have been, second-generation drugs, have been compared with carbamazepine mostly in well-designed, randomized control studies in patients with newly diagnosed focal epilepsy, And these drugs are oscarbazepine, lamotrigine, gabapentin, topiramate, levetiracetam, vigabatrin, zonisamide, lacosamide, as carbazepine acetate. And the key message that has emerged from all these studies is that none of the newer anti-seizure medications have been found to be more efficacious than the older drugs. And in fact, of those that are listed here, gabapentin and vigabatrin were actually found to be less efficacious than carbamazepine. There was one study that I'm showing you as an example, is one of the largest studies ever done in newly diagnosed epilepsy, included mostly this arm of the study, patients with focal seizures. It's SANAD, the name of the study, conducted in the United Kingdom mostly. And in this study, patients were randomized to 4 second-generation drugs or to carbamazepine and followed up, as you can see here, which is the most solid part of the study, for 4 years. And what the slide is showing is the proportion of patients remaining on treatment, which is a combined measure of efficacy and tolerability, because you remain on the allocated treatment if your seizures are controlled and you can tolerate the drug. And carbamazepine is shown in purple, and you can see that overall the various drugs that were assessed in this trial, lamotrigine, oscarbazepine, and topiramate, had a retention on treatment very, very similar to that of carbamazepine. One drug, and that was gabapentin, did actually worse, with fewer patients remaining on treatment after 4 years, and the difference was not due to tolerability, which was very good for gabapentin, but for lower efficacy compared with carbamazepine. SANAD, in the same trial, also had an arm where patients with newly diagnosed generalized or unclassified epilepsy were included. And in this arm of the study, broad spectrum drugs, that is valproate, lamotrigine, and topiramate, were compared. And again, you see the retention on treatment. And the winner in this comparison of 3 drugs was valproate, which had the highest retention. Lamotrigine had an intermediate retention and did not do as well as valproate, mostly because of lower efficacy. And topiramate was the drug that did least well, and that was mostly because of inferior tolerability to both valproate and lamotrigine. One limitation of SANAD is that it was started many years ago, and levetiracetam was not established yet. So a second SANAD study has been implemented to compare specifically valproate with levetiracetam with valproate. And I'm showing the results here. They are not published in full, but they were presented in 2019 at the International Epilepsy Congress. And as you can see in the summary slides, in time of treatment failure, time to first seizure, treatment failure due to lack of seizure control, valproate was better, and levetiracetam did not do as well as valproate on any of the parameters related to efficacy. And in terms of tolerability, treatment failure due to adverse events, there was no difference between valproate and levetiracetam. So again, in generalized and unclassified epilepsy, levetiracetam did not do as well as valproate. Well, one limitation of the SANAD studies is that the data were presented for, at least in the main slides, for the combined, pulled together different syndromes. And it would be desirable, of course, to look at efficacy within specific syndromes. Few studies have actually been done with adequate power to compare efficacy. The best one, in my judgment, is the study conducted by Tracy Glauser and colleagues in the US a few years ago, when they looked in a double-blind randomized study to valproate, etosaximide, and lamotrigine in children with childhood absence epilepsy. And what the slide shows is that success rate, meaning percentage of children who were free from seizures, including EEG recording, and tolerated the medication well. And as you can see, valproate and etosaximide had a similar response, but lamotrigine was inferior, with almost 1/2 of children on lamotrigine remaining successfully on treatment compared with those allocated to valproate and etosaximide. There was also one study that looked specifically at one syndrome. It was a little bit atypical because it was conducted in newly diagnosed epilepsy, and again, absence epilepsy. These were children with childhood absence epilepsy and also juvenile absence epilepsy, but no generalized tonic-clonic seizures. And in these patients, for a short time, it may be ethically justified to try a placebo. So levetiracetam was compared with placebo for up to 2 weeks. Levetiracetam was given up to a dosage of 30 milligrams per kilogram in this study. And as you can see, there was a trend for levetiracetam to do better than placebo in controlling absence seizures, but the efficacy was not impressive. And actually, in the main primary endpoint, it failed to reach statistical significance. During the open label follow-up study, all patients went on to receive levetiracetam, but eventually many had to be switched to valproate or etosaximide because the response to levetiracetam in many patients was not adequate. So the summary, based on the data that I've just presented, is that the overall second-generation medications have not been found to be more efficacious than the older drugs. Admittedly, there are people who do not respond to older drugs and may do well to second-generation compounds. However, the reverse is also true. And I also need to point out that we don't have high-quality comparative trials specific for a given syndrome. In the majority of the generalized epilepsy syndromes or developmental and epileptic encephalopathies. So this is an area where we definitely need better studies. Now, what about tolerability? Are second-generation drugs better tolerated than older drugs? Well, I would argue that although this is often stated, in fact, the question is artificial. It depends which drug we are considering, depends which dose, and depends on which population of patients we are looking at, depends on the characteristics of the patient. It is true that some of the newer generation drugs have some tolerability advantages, for example, with respect to effects on cognition. But it's also true that we have many second-generation drugs that can produce even life-threatening adverse reactions. Virtually all can induce serious adverse reactions to the extent that drugs such as, for example, valproate, such as vigabatrin or felbamate are only reserved to selected cases. What we need to emphasize is that each drug is different from the others in adverse effect profile, indications and contraindications in special groups, and therefore we need to tailor the selection of the drug to the characteristic of the patient. If you want to have a broader look, and it is what Martin Brode and his group did in this study, which was published very recently in JAMA Neurology, well, you can look over the years to the percentage of patients who have been started, newly diagnosed, who have been started as monotherapy on older and newer medications, and see what proportion discontinued treatment because of intolerance. And what they did specifically in the study was to compare the 3 cohorts. One cohort that started on treatment between 1982 and mid-1992. And as you can see, only 20% of patients in this cohort are receiving a second-generation drug. So the older cohort was mostly a cohort treated with older drugs. If you look at the newest cohort, July 2002 to April 2016, in this cohort, as almost 70% of patients were on second-generation drugs. And then the intermediate cohort is patients who were treated in between. And what you find here is the percentage of patients who could not tolerate the drug that was given to them. As you can see, those that received mostly older medications, 10% did not tolerate the drug. And those that received mostly second generation drug, it was actually 14%, not a significant difference, but there was clearly no indication that overall the newer medications resulted in less patients discontinuing due to intolerability. This is one side only of the coin, because there are many patients who do not discontinue the drug but still have adverse effects. And here there may be the two differences between at least some older generation drugs and second generation drugs. One aspect where there are definitely differences is with one specific adverse effect, and that is teratogenicity. And what is showing in this slide, it was kindly lent to me by Dr. Thompson, is a proportion of data from 3 different pregnancy registries showing percentage of babies that were born with major congenital malformations. And this is data from the Europe registry, the circles, the North American registry, the triangles, and the squares would be the UK and Ireland Epilepsy and Pregnancy Register. And as you can see, for each drug, the data shows some modest differences across registries. For example, for valproate, Europe and the North American registry gave slightly higher malformation rates than the UK and Irish registry. But overall, the messages are rather consistent across the 3 registries and indicate the highest risk, and we all know that, is associated with exposure to valproate. Then second in terms of risk would be phenobarbital. And then somewhat intermediate, but on the lower side, we have phenytoin, carbamazepine, and topiramate. And then the lowest risk, and again, the data across registries is consistent, the lowest risk would be levetiracetam, lamotrigine, and oscarbazepine. Again, when we are discussing adverse effects, we need to take those into consideration. So Europe had a large cohort and also looked at doses. And this is what is shown here for some drugs, and that is valproate, phenobarbital, carbamazepine, lamotrigine. There was a dose dependency in malformation rate. And that was especially striking for valproate and for phenobarbital. You see that at the dose of greater than 1450 milligrams per day, 1 child out of 4, 25%, exposed to valproate was malformed. But then if you go to a low dose of valproate, 650 milligrams per day or less, then the proportion of malformed baby was clearly much less, and comparable to the intermediate dosage group for phenobarbital, or for example, to the combined groups of carbamazepine, more than 700 or 700 milligrams or less. And also you remember from the previous slide that phenobarbital came second in terms of risk for teratogenicity. However, again, here there is an important dose dependency, and at 80 milligrams or less of phenobarbital, the risk was actually quite low. So this emphasizes the point that dose is as important as the type of medication with respect to teratogenic risk. And again, the second generation drug included in this slide, which is lamotrigine, was actually associated with the lowest risk. Levetiracetam is not shown in this slide because it is also associated with reduced risk, but very similar overall to that of lamotrigine. But in the case of levetiracetam, there was no dose dependency in risk, which was overall comparable to the pooled cohort of patients, of babies who had been exposed prenatally to lamotrigine. So these data clearly overall indicated that there are still advantages, in this case in second generation drugs, some second generation drugs in terms of teratogenicity risk. For some drugs, actually, we don't have enough information yet. Then discuss briefly drug interactions, which is one aspect of safety. And if we ask the question whether second generation drugs are less likely to cause clinically important pharmacokinetic interactions, then we can answer yes, and with some exceptions. However, we also need to consider that many second-generation drugs do not cause pharmacokinetic drug interactions, but they can be victim of clinically important pharmacokinetic drug interactions. And Lamotrigine is one example here. Lamotrigine does not affect the blood levels of other drugs. However, the blood levels of Lamotrigine are markedly affected by enzyme inducers, for example, by carbamazepine, phenobarbital, or phenytoin, or by enzyme inhibitors, for example, valproate, and also by other drugs as well. For example, the oral contraceptives can decrease markedly the levels of Lamotrigine. And all these interactions that I've been describing have a marked influence on the dosage requirement for Lamotrigine. And we all know that we have to give, for example, lower starting doses and there's lower titration rate when we add Lamotrigine to patients who are on valproate. Importantly, there are also pharmacodynamic interactions that we need to consider. And here, second-generation drugs can be as influenced as first-generation agents. With respect to pharmacokinetic interactions, the most important of those interactions are those caused by enzyme induction. And here I want to point out that the main enzyme inducers are actually older generation drugs: phenytoin, carbamazepine, and phenobarbital and primidone. And then we have a number of second-generation agents that you see here. They have a weaker or more selective induction, meaning not all drugs may be affected by enzyme induction when patients taking these compounds. Although, for example, if you look at the interaction between oscarbazepine and deslicarbazepine acetate and the contraceptive pill, the decrease in blood levels of steroid contraceptives is very similar with oscarbazepine and deslicarbazepine to what you find, for example, in patients exposed to carbamazepine. So you have to look on a case-by-case basis. But generally speaking, phenytoin, carbamazepine, phenobarbital are more powerful and more broad spectrum as enzyme inducers. And when it comes to enzyme inhibitors, perhaps the one that we need especially to consider is valproate, with respect especially to inhibiting the blood levels, to inhibiting the metabolism and increasing the blood levels of phenobarbital and Lamotrigine, and we all know that, but also some second-generation agents can act as enzyme inhibitors, and the most important ones here are definitely cannabidiol and stiripentol, which are powerful inhibitors of CYP2C19, and by this mechanism increase several-fold the blood levels of norclobazam, the active metabolite of clobazam, and this is a clinically important drug interaction. Enzyme induction, we need to remember, is not only a cause of drug-drug interactions, but can also cause iatrogenic disease. Vitamin D deficiency, disturbances in steroid hormone metabolism, including sex hormones metabolism, alterations in serum lipids, and in this respect, second-generation drugs that are not enzyme inducers have some advantages with avoiding some aspects of the chronic toxicity related to enzyme induction. I mentioned before pharmacodynamic drug interactions because these interactions relate to the mechanism of action. They do not affect the blood levels, but they related to how drugs interact at the site at which they act in the brain. And this is a very complicated slide which shows the different sites at which anti-seizure medications act on the excitatory and the inhibitory synapse. I cannot spend much time to discuss this, but I just want to point out that some drugs do act by very similar mechanisms. For example, levetiracetam and brivaracetam, they both act at the same site as the SV2A molecule with a very similar action. And then we have a long list of compounds that you see here. I put a circle around it, and all these compounds act fully or in part by blocking voltage-gated sodium channel. And knowing the mechanism of action is important for the clinical use of drugs for a variety of reasons. For example, if a patient has failed on one anti-seizure medication, well, theoretically, it makes sense next to try a drug which would have a different mode of action. And we know that combining drugs with different modes of action tends overall to give more favorable profile, whether when we combine drugs with identical mode of action, we may expect to have a higher risk of adverse effects and lesser degree of efficacy overall as a general consideration. What I've done in the next slide is try to summarize current evidence about interactions, pharmacodynamic interactions, which result in less favorable effects when these medications are combined. You may combine some of these medications. Some of these combinations are especially not very rational, but overall, if you look at the data, there is a higher probability, for example, of patients encountering adverse effects when these drugs are combined. And all these combinations have in common the fact that the drugs shown here, when all these combinations are combinations of drugs which act by the same mechanism. For example, levetiracetam and brivaracetam, we mentioned that before, and all the other combinations are actually combination of sodium channel blockers. There was several studies that have been done looking at it, and I summarized them in the previous slide, but this is one of those I can draw your attention to, and this is a study where they looked at patients receiving different combinations of drugs, and what they concluded is that combinations of drugs acting by different mechanisms had greater effectiveness as measured by retention on treatment and the lower risk for hospitalization and visits to the emergency department. So a finding which is very consistent with the consideration that we just made. And if you want, again, additional evidence about this, I'm showing here the result of a pooled analysis of studies from placebo control add-on in patients with uncontrolled seizures that were given brivaracetam, looking at two separate populations, patients in whom brivaracetam was added on to people who were not receiving levetiracetam, and you see a nice dose-response relationship. The higher the dose of brivaracetam, the greater the reduction in seizure frequency. And then what you find here in this side of the slide is instead the response that was observed when brivaracetam was added on to patients who were already on levetiracetam. And in this group, there was no reduction in seizure frequency. If anything, there was an increase in the frequency of seizures. Again, emphasizing that brivaracetam is not effective when it is combined to levetiracetam, presumably because the receptor sites are already occupied and you cannot get a greater effect at those sites. The combination for which there is the best evidence of a favorable synergistic activity is the combination of lamotrigine with valproate. And this is a result of one of several studies that have been done. In this study, lamotrigine was added on to patients on monotherapy with valproate or carbamazepine or phenytoin. And as you can see, the best response was when lamotrigine was added on to valproate. When it was added on to carbamazepine or to phenytoin, there was some seizure improvement, but not as much as it was seen with the combination of lamotrigine and valproate. And by the way, the dosage was adjusted in a way that blood levels were kept of lamotrigine were kept similar across the three groups. So the better response in people who received lamotrigine with valproate was not due to higher lamotrigine levels in patients who were on valproate. This is also a difficult combination to use because, as we have just discussed, Valproate is an inhibitor of lamotrigine metabolism, and you need to titrate lamotrigine very slowly in these patients to avoid the risk of skin rashes, including serious skin rashes. So I'd like to move on and very briefly have an overview of what has been the overall impact of the second generation drug in terms of efficacy and safety. And because I have limited time, I direct you to this very recent publication, which we did with some colleagues, and you can go through it and get more details about what I'm going just to say very, very briefly. In terms of efficacy, I'm just showing you the best evidence that we have, and that was again looking at cohorts of patients followed up after starting initial monotherapy over time in different periods. So in this particular study, 3 cohorts were compared. The oldest cohort is for people who started treatment between 1982 and 1991. And as you can see, 21% of this cohort received second generation drugs, so 80% were on older medications. And again, the newest cohort, 2002-2012, where 75%, 3/4 of the patients were on second generation drugs. And what the slide, which is taken from a single center analysis by Martin's Brody's group, what he showed here is that overall, the percentage of people who achieved seizure control after a long-term follow-up did not change at all. When the initial treatment was mostly older generation drug, or lately when patients were mostly started on second generation medication. So this reinforces, if you will, the evidence that we have discussed before, that the impact in terms of seizure response has not been much improved by use of the second generation drugs, because these medications overall do not have great efficacy. So if we want to make a conclusion about the impact on seizure outcomes, unfortunately, we have to say that about 1/3 of people with epilepsy still do not respond to available drugs. And that was the same as in 1967. We had 22 drugs introduced in the last 50 years, but they control seizures in, I would say, no more than 15% of people that are resistant to the older drugs. And also there are limitations because, again, as we said at the beginning, even the latest drugs that have been introduced are drugs which suppress the seizures but have no effect on the underlying disease. With respect to safety, there is one area where definitely there has been an improvement, and as you may imagine, is with respect to teratogenic risk. What I'm showing here is data from the Europe registry showing over time, and these are patients collected internationally, we can see over time how the treatment of epilepsy has changed. For example, for the year 2000 to the year 2013. And you can see that in the year 2000, the large majority of patients were receiving first generation drugs. It was mostly the yellow carbamazepine and the blue valproate. Some patients were on phenobarbital, a few were on phenytoin, and newer generation drugs were only lamotrigine, levetiracetam, and scarbazepine, but used overall in about 15% of patients. And you know what has happened over the years. Now the first generation drugs are much less frequently used, and the majority of patients now became pregnant, received lamotrigine or levetiracetam or scarbazepine if you receive topiramate. And especially, as you will see, there was been, for obvious reasons, a drastic reduction in the utilization of valproate during pregnancy. And this has resulted definitely in different outcomes. This is the proportion of babies born overall in the pregnancy registries with all the drugs that the women were taking at that time. In the early period, 2000 to 2005, 6% of babies included in the registry over that period had major congenital malformations. If you go to 2010, 2013, the percentage overall in the pool population has dropped to 4.4%. And it was shown that this major drop is about 1/3 in terms of drop, was attributed, could be clearly ascribed to the reduction in the percentage of women who received valproate over this time. So let's say a few words now about the role of second-generation medications in the current treatment. Well, I would summarize that by saying that now that we have so many drugs, we have really unprecedented opportunities to tailor the selection of the medication to the individual needs. And overall, definitely, we have now many second-generation drugs that are valuable options for first-line monotherapy. So it's perfectly justified to use many of the, or some of the second-generation drugs for initial monotherapy. They offer some advantages, including with respect to long-term tolerability. And their use, I would say, is especially justified in patients who are at risk for drug-drug interactions, including the elderly, and we will hear shortly a talk about it from Dr. Hassan Hosni, or patients at risk for certain adverse effects. And females would be one example for which we have presented data. So what we have to do when we utilize medication these days is to consider the properties of the drug, the spectrum of efficacy. We discussed this. We discussed the importance of mechanism of action with respect especially to drug combinations. Consider the approved indications that may vary, they do vary from country to country. Consider the magnitude of efficacy, and we have already discussed that. Consider the different adverse effect profile. Consider the impact of comorbidities. We know comorbidities are common in people with epilepsy. Some drugs can aggravate comorbidities, some drugs can improve comorbidities, and that is a consideration. Consider drug interactions. And consider ease of use. Ease of use is a bit of a combination of all of the above. If a drug is broad spectrum and has low risk of adverse effects, it would be easier to use. But ease of use also includes how difficult the titration scheme would be, whether you would need to use blood levels, or is it desirable to have blood levels to adjust optimally the dosage, whether the drug can be given once daily or twice daily, or you need more frequent administration. Whether, for example, there is a palatable and easy to use formulations for children, and so on and so forth. And last but not least, of course, cost, which is important in every context. And here in general, second-generation drugs are more expensive than older agents. And then consider at the same time the individual characteristics. And so you have to consider all these factors, including socioeconomic status, because that is relevant for cost and for some of the other considerations, and try, and this is what I would especially emphasize, to discuss all these points on the left with the patient to make sure that eventually you come to a decision which is not the decision you impose on the patient, but is a decision that is taken together after providing all the necessary information by you as a physician and by the patient. And if you take that medication together, you have a greater probability that you will be successful, that there will be good compliance, good adherence, good relationship between the person with epilepsy and the doctor, which is absolutely essential for a successful outcome. I'd like to close my presentation with a few words about drugs in clinical development, because it's clear from what I just said that none of the currently available medications is ideal. We need new drugs. What I'm showing in this slide is a number of medications which are in clinical development right now. And this is just to emphasize the fact that fortunately, research into finding better treatments for epilepsy is still ongoing, and there is still hope that we will come up in the future with even better medications than what we have right now. But I'd like to close with saying that what we are seeing these days is a change in the paradigm by which drugs are developed. And I'm showing you the 2017, the modern ILAE classification of seizures and epilepsy. And of course, the first thing that we start by trying to identify the seizure type. Then we move on to try to determine what type of epilepsy a patient has, and then the epilepsy syndrome. But the classification has other components, comorbidities, and we will discuss that. But most important, the modern classification scheme has this column, most important column, which is etiology. It's more and more important to recognize the etiology of the epilepsies that we diagnose in our patients. And this is becoming very, very important for drug development. For the last, I would say, 100 years, we've been focusing on developing treatments against seizures. And we developed a variety of seizure models and try to develop drugs that symptomatically affect the seizures. And we did not pay much attention to the etiology and to develop drugs that could actually impact on the mechanism by which a given etiology leads to development of epilepsy. And this is changing now. I'm just giving you as an example the genetic epilepsies. We know that lately, thanks to next generation sequencing, we are discovering at a fast rate a wide variety of epilepsy genes whose mutation causes epilepsy. And once you have identified the gene that causes epilepsy in a given individual, you can work back on what is the function of the gene and how that mutation that has caused the epilepsy has affected the function of the gene. And then once you have understood that, then you can develop rationally a treatment that will correct that dysfunction. And that would be the most rational way by which we could develop drugs. So in the old days, this is a traditional model. We started with chemicals, with compounds. We targeted the seizures. We did not bother about what was causing epilepsy. We did not do functional studies. We mostly studied chemical entities. And it was all the time new compounds we were developing. Now, the new model is to start with the disease, understanding the disease and the mechanism, first of all. Then we are targeting, in that case, the epilepsy. We have a precise molecular explanation. We know the function of the gene, or it may not be the gene, it may be an immune mechanism, or it may be the mechanism by which an infection can cause epilepsy, maybe brain inflammation, whatever you want. And by doing so, you can develop a treatment directed to the etiology, which may not just necessarily be a chemical treatment. It could be gene therapy, for example, and include repurposed drugs. And here is a variety of compounds. It's just one example. In the future, for some of the epilepsies, we may be using atorvastatin or aspirin or amlodipine. In other words, drugs that are already in the market whose safety has been well established. And we may expect the dose that will work in humans to be within the range for which safety is already very widely established, and sometimes even lower than that. Having said that, of course, for each of these drugs, you will need careful validation studies, high-quality clinical trials to define precisely whether what we expect to find based on animal studies is reflected in the clinic, and what would be the precise indications or contraindications of these agents. So I come to the conclusion. I would argue as a conclusive point that distinguishing between first and second generation drugs is an artificial thing. We should consider each medication on its own merit. We have now 30 different drugs, which gives us, as I mentioned before, excellent opportunities to tailor treatment to each patient needs. However, I would also argue that having so many drugs, it becomes very challenging, especially for the non-specialists who may not be familiar with the mechanism of action, indications, contraindication of specific medications. So there is a risk that so many drugs available also results in suboptimal use, at least of some of them. And you will agree there are still major unmet needs in epilepsy treatment, but fortunately, we are now seeing novel strategies for drug discoveries, and we may have indeed, through these strategies, more efficacious treatments in the future, hopefully including drugs that will be not just anti-seizure, but also really anti-epileptic or anti-epileptogenic. And with this, I thank you for your attention, and I look forward to having with you a good discussion of these points now. Thank you very much.
Thank you, Emilio, for this interesting talk, which summarizes current data. Before taking a question from the audience, I had some question. You have said the rate of refractory epilepsy is almost the same since 50 years. For developing countries, what are your favorite drug medication?
I don't think you can answer that. It depends on which country, depends which medications are available in each of the countries. What WHO still says, and there is some sense in it, is that phenobarbital is still a very valuable treatment when you have people who cannot afford to spend sometimes more than a few cents of $1 per day for the treatment. But unfortunately, phenobarbital, even in the developing countries, is poorly, not affordable, but is poorly accessible because of many regulations that restrict import and distribution. So even in many developing countries these days, it will still be the older medications such as carbamazepine or valproate. But we need to remember that generics have made many of the new medications cheaper. So drugs such as levetiracetam and the Lamotrigine are now relatively affordable in many countries. And there are manufacturers in developing countries that can make these drugs available at a relatively low price.
Yes. Okay. And if I understood your conclusion, in fact, the ideal situation is to have each drug correspond to one epileptic syndrome.
Well, I will not even say that. Syndrome is one of the factors to consider. But for patients having the same syndrome, the drug may vary depending on gender. For example, JME in a male would be valproate, but JME in a female may not be valproate, may be levetiracetam, for example. And then the comorbidities and many other factors as well. So syndrome is a very important component, but not the only one.
Yes. Okay, now we'll take the question from the audience.
Well, I've seen some questions from the audience. Maybe I can answer them because I've been writing them down and I can do that rather quickly.
Yes, if you like.
I think
yes.
Charles had a very good question about whether stiripentol would be efficacious in other epilepsies other than Dravet syndrome. And the answer is, the question is very good, but we don't know that answer. But what we do know is that the pathophysiology of epilepsy in Dravet syndrome is a loss of function of GABAergic interneurons. And we are not so sure that that is the same in other forms of SCN1A related epilepsy. So we will need to do some studies also in other forms, but I think it will be an interesting thing to do. And I also like to say that, for example, epilepsy due to a loss of function, SC1A mutation, tend to be aggravated by sodium channel blocking drugs such as carbamazepine. So for example, focal epilepsy, some patients with focal epilepsy due to SCN1A mutation are aggravated by carbamazepine, even if they have focal seizures. So there may well be a possibility for stiripentol to be of value in these patients. There was also one question about whether there are promising anti-seizure drugs that are also anti-epileptic. And the answer is we have animal data so far. We don't have good clinical data indicating that we really have drugs which are anti-epileptogenic or disease modifying, the way you want to call it. But there is a lot of research going on there. And perhaps in the future, drugs that act on different targets, let's say as an example, brain inflammation, may prove to be anti-epileptic, not just be anti-epileptogenic. But also we need to remember that when we do a drug, when a drug targets a specific etiology and is given very early, that drug may well be able to have a much broader impact than the impact on seizures. And we see that in the epileptic encephalopathies. If we start very early the treatment and we stop the seizures, we often are successful in preventing cognitive deterioration and intellectual, eventual fallout. It's whether that is just a consequence of an effect of seizure or there are other effects, we don't know. But I think the future is going to be in that direction. You had other questions, Reda?
Yes. In refractory epilepsy, when a multitude of drugs are used, is there a limit for the maximum doses of drug when are multiple? I'm asking about the total drug load and how is measured.
Yeah, well, again, this is a good question. I don't think there is a fixed rule. We cannot say you cannot give more than, say, 1,200 milligrams carbamazepine in somebody is at the same time of phenytoin of lamotrigine. But generally speaking, the greater the drug load, the more you are likely to encounter difficulties when you increase the dosage of other drugs that you add, because tolerability is somewhat related to drug load. But it's not a mathematical relationship because, as I've shown, it depends on the mode of action. If you add on lamotrigine to carbamazepine, very soon you will encounter adverse effects due to neurotoxicity. But if you add on lamotrigine to a non-sodium channel blocker, you will be able to increase more the dose of lamotrigine without side effects, irrespective of the drug load. So again, it's not so much the drug load, but the type of combinations that you are using, and also the way individual patients respond. And we don't fully understand that, but each patient responds in a different way. And how do you calculate the drug load? There is a formula which you use the defined daily dose. You find that in the internet. It's calculated by WHO. And you calculate the drug load by adding the defined daily doses of all the components of the treatment that each patient is receiving. So, for example, if a patient is receiving 1 gram of carbamazepine, which is the defined daily dose of carbamazepine, and 1 gram, I think, of levetiracetam, which is a defined daily dose of levetiracetam, well, that patient will be on a burden of 2, 1 daily dose of one plus 1 daily dose of another one.
Okay. When we add to valproate lamotrigine in addition to slow titration of lamotrigine, shall we diminish the dose of valproate?
The answer in general is no, because lamotrigine does not affect the levels of valproate. However, in clinical practice, you do encounter some patients who may develop some side effects that seem to be related to valproate when you combine these two drugs. And in that case, you may consider reducing the dose of valproate. This is especially true for tremor. Some patients on this combination develop tremor or have an increased intensity of a pre-existing tremor, which is a side effect of valproate, of course. And you may need to manage that by reducing the dose of valproate. So generally no, but in some patients, depending on tolerability, you might have to do that.
Okay, I think it will be the last question because we have to move to the second session. For neonates, which drug considered first line for seizures? Phenobarbital, levetiracetam, or topiramate?
I think I passed that to you. I'm not a pediatric neurologist, and I really have not enough experience with use of these drugs in neonatal seizures. I know that phenobarbital is still widely used by a lot of colleagues, but I'm not aware of good comparative studies. And I would really deflect the question to a pediatric neurologist in one of the next webinars.
Okay, thank you very much, Professor
Thank you, and
Emilio
thanks everyone
Perucca.
for taking part in this. We see we have a good audience, which is great.
Thank you. Now, Fatima and Hassan, you hear me?
Yes. Yes. Thank you, Professor Perucca, for the session. And we'll move now to the second presentation. The speaker is Dr. Hassan Husni, who is the Professor of Neurology and Epileptology at Cairo University. Professor Hassan had his training in epilepsy in the USA at University of Chicago and at the Cleveland Clinic Foundation. He is currently the Secretary of the Egyptian Epilepsy Association and is the Vice President of the IBA for the Eastern Mediterranean region. Professor Husni also served twice of the Eastern Mediterranean Commission. So his talk today will be on seniors and epilepsy. And Dr. Hassan, the floor is yours.
Thank you, Fatma, for the introduction. And hello, Emilio, thank you for the talk. And thank you, Reda, for being a moderator. My talk today will be about seniors and epilepsy. I thought the term senior is more better than elderly in epilepsy because I think it's more of a respect compared to elderly population. My talk today, there was an article in Neurology Today that general neurology is a dying specialty. But still, when I prepared this talk, I thought this talk was very appropriate to specialized neurologists, whether you're dealing with stroke patients, whether you're dealing with memory clinics, and even for neurosurgeons dealing with traumatic brain injuries and tumors. So it's not just for the epileptologist, it's for broad specialties apart from neurology. So why the elderly? There's an increased incidence of seizures and epilepsy in the elderly, and this could be simply because of increased related and aging-related epileptogenic conditions. My outline of the talk will be, if you look at the numbers definitely are seizures are more in the elderly. Mechanism of action, it's not very well understood, but seems it's related to aging and neurodegenerative problems. Etiology is different from the younger population or the younger population. Clinic presentation is a bit problematic because you don't get really the seizure types we're used to see in EMU, epilepsy monitoring units, and by history. So the clinician has to be very wary about the diagnosis. Unfortunately, there's an underdiagnosis and misdiagnosis in the majority of cases. Treatment approach is a bit different because of the comorbid conditions. I'll be focusing on strokes as it's mostly in the elderly it happens, and dementia, mainly Alzheimer because of the disease of the elderly, post-traumatic epilepsy and status epilepticus, which is certainly more common in the elderly. And I like this slide because it tells you, if you look at this case of epilepsy or seizures, simply looking at the age, you can suspect the etiology of the seizure. And you can see, for example, a genetic generalized epilepsy, it comes with the teenagers. And usually we think above the age of 20, you're dealing with partial onset seizures. And definitely above the age of 60, you can see the rising numbers of epilepsy in the seniors or elderly population. So simply we're talking about 65 years old. The age-specific incidence is look at between 45, 59 years is 10 in 100,000. If you go from 60 to 74, it's 25. And if you reach above 75 years, you have a high percentage of seizures, 101 per 100,000. In addition, the incidence of acute symptomatic seizure is also higher with increasing age. The elderly definitely are more prone to developing a first unprovoked seizures. The incidence is in different studies. What's important, status epilepticus is 2 to 5 times more common in the elderly than in young adults, with an annual incidence of 86 per 100,000 in individuals over the age of 60. And the mortality rate is quite high in status epilepticus in the elderly population, and it can reach up to 50%. The causes of new onset epilepsy and seizures in the elderly are different from the younger population. And you can see cryptogenic 50% of cases unknown, but still it's it's partial onset seizures, stroke from 30 to 5%, dementia, mainly Alzheimer comes next, 10 to 20, tumors and trauma. There is being increasingly recognized the issue of paraneoplastic and autoimmune causes. Idiopathic generalized or genetic generalized epilepsy is quite rare at this age group. We should not forget, before diagnosing an elderly with epilepsy, we should not forget we see often acute symptomatic seizures. In acute stroke, you see it, symptomatic seizures, metabolic electrolyte imbalance in diabetics, in renal problems, in tumors, in trauma, drug-related seizures. Elderly are very prone to adverse effects of different medications, antibiotics, and a lot of other medications. So you can see provoked seizure and central nervous system infection. So I think it's very important before deciding this patient is epileptic, you should think of acute symptomatic seizures in the elderly population. Clinical presentation is a bit different compared to the younger. You don't find the GTC, generalized tonic-clonic seizures. Mainly it's non-specific, and unfortunately symptoms are not easily recognized and usually attributed to aging and other medical disorders, as a lot of patients have comorbid conditions. So underdiagnosis and misdiagnosis are quite common. The clinical presentations is mainly impaired awareness, or impaired awareness, as Dr. Perucca was mentioning about the new classification. The semiology is just the mainly. In partial onset seizures in the elderly, you see more of frontal more than temporal, as in stroke patients. Stroke patients get seizures are more stroke frontal insults compared to temporal. Don't expect to hear about auras or automatism in the elderly population. They don't exist. Increased frequency of atypical events, memory lapses, confusion episodes, and altered mental status. And this is quite perplexing in taking the history. The other very important point is the post-ictal states. The post-ictal state is quite prolonged following seizures in the elderly. And you can misdiagnose the patient as having dementia or even having a stroke if he gets the post-ictal weakness, and it can last up from 7 days up to 2 weeks. So I think this is really important. What's more important is differential diagnosis of epilepsy in the elderly, because a lot of symptoms mimic the seizures in the elderly. You see often TIA, transient ischemic attacks. It could be an active motor seizure. You see the transient global amnesia. You see it a lot. It's not rare. This is very important. You look at the metabolics, especially diabetics with hypo and hyperglycemia and electrolyte imbalance. Syncope with arrhythmias, it's common. Sleep disorders as REM behavior disorders, as a neurodegenerative disease. Parasomnias. Of course, very important, sick sinus syndromes and other arrhythmias, which often are seen and underdiagnosed, and patients are diagnosed as having epilepsy. Psychological factors are common, and you see some non-epileptic psychogenic seizures also in the elderly. What's the prevalence and clinical correlates of non-convulsive status epileptics in the elderly patients with acute confusion states? This is very important because the semiology is also perplexing, and it confuses with other symptoms. So the non-convulsive status epilepticus manifests as altered memory, unusual behavior, and unresponsiveness. It accounts from 4 to 20% of cases of status epilepticus. It's very important to say that 1/3 of patients only have a history of epilepsy. High mortality, around 50%. However, it's related to underlying process or underlying the pathology rather than duration of the non-convulsive status epilepticus. And the VA studies found that 65% of patients with non-convulsive status died within 30 days of an episode, compared just to 27% with generalized tonic-clonic seizure, generalized convulsive status epilepticus. So this is important to recognize the non-convulsive, especially on the brain encephalopathies. If you look at the prognosis of status epilepticus, convulsive status epilepticus, it's a serious condition of prolonged and repetitive seizures. The annual incidence is 86 in 100,000 over the age of 60, twice as common in the general population. half of status epilepticus do not have a diagnosis of epilepsy. However, it's triggered by acute illnesses, and mortality definitely increases with age, etiology, and duration of the status. The commonest focal pathology resulting in epilepsy in elderly is strokes. So definitely we're talking of strokes. We have the early onset, the early seizures, and the late seizures. The early seizures are mostly, of course, as symptomatic seizures, acute symptomatic seizures. And it's important to not designate the patient as epileptic. Late seizures, they find occur more often after 14 days. This type of seizure is also known as unprovoked seizures. And this is important to differentiate between the two. The risk of subsequent unprovoked seizures was 33% among patients with the first symptomatic seizure. So the patient with the first acute symptomatic seizures, 1/3 will have recurrent seizures, and 71% will have a recurrence after the first unprovoked seizures. So the quite high percentage of recurrence of post-stroke epilepsy after the first seizure. So I think it's better just to put the patient on anti-seizure medication. There's also an interesting issue about the relationship between stroke and epilepsy, that it's bidirectional. So the risk of stroke is increased 3 to 4-fold in patients with late onset epilepsy. So this is interesting. It needs to be further studies if patients with late onset epilepsy develop stroke later on. Another study is looking at the neuroimaging, whether the white matter, hyperintensities, cortical volumes, and the link to late onset epilepsy. Just one study, and I didn't find any other studies commenting on this paper. Of course, late onset epilepsy, first thing we do is neuroimaging. So in emergency, you do for the first seizure or acute symptomatic seizure, you do the CT brain or the MRI, and this is a case. This is a man of 65 years. He had the hematoma. He had no seizures, so he was not in treatment. Okay, 4 years later, he presented with the first seizure. That's what we call the post-stroke epilepsy. And this is an EEG. It's very clear that you can find slowing on the right hemisphere, but I have to mention that the findings on EEG are quite scanty in patients, elderly patients with epilepsy. And this slowing is not definitely related to the epilepsy, but simply this slowing was related to the hematoma on the CT. And this EEG was done after he had the hematoma. So it's very important to recognize that EEG is not very helpful in cases with late onset epilepsy. The epileptic form discharges in general decrease as we age. How about dementia and epilepsy? Dementia is we have the Alzheimer's dementia, we have the non-Alzheimer's dementia. Seizures are more common with Alzheimer's dementia. 10 to 20% of epilepsy in the elderly is due to dementia and cognitive impairment. Alzheimer's dementia is best studied and associated with high rate of epilepsy than other dementias. 10 to 20% of Alzheimer's patients have epilepsy. The incidence of seizures increases with the disease progression. So this is important if you work in a memory clinic and you follow up the patient. This is what you expect to see epilepsy with the Alzheimer's more than non-Alzheimer's dementia. However, I have to mention that recently we see patients younger, under the age of 60, with Alzheimer's dementia or with dementias. I don't say Alzheimer's because the Alzheimer's frontotemporal or whatever. And they have an 87 times higher to develop seizures compared to the general population. I think this slide is important to neurologists who work in memory clinics. We always, in neurology or in epilepsy, you try to find biomarkers. And this paper was looking at biomarkers of epileptic form discharges in seizures in Alzheimer's patients. And that's what they found, that the epileptic form abnormalities are common. And around the epileptic form abnormalities were seen in 53% of Alzheimer's dementia with epilepsy, 22% of Alzheimer's with no epilepsy. So it's quite common to find, it's not common, I mean 22% no epilepsy, but they found epileptiform discharges. So they found that, what they found is that epileptiform abnormalities are common in Alzheimer, but not all are equivalent. Specific features are associated with clinical seizures in Alzheimer's disease. Given the difficulty recognizing clinical seizures, it's not easy to diagnose seizures often because of the cognitive impairment in Alzheimer. These EEG features could provide guidance in which Alzheimer's dementia patients are at a high risk for clinical seizures. So this is just thoughts about whether the EEG will help you in picking up Alzheimer's patients with seizures. Another etiology is the post-traumatic epilepsy. Age of 65 or more is one of the risk factors of developing epilepsy after head injury. This is well known, and of course seizures lead to fall. So this is important. Patients with trauma, subdural hematomas, are prone to having post-traumatic epilepsy. And this is a paper from Japan looking at the influence of age on the outcomes of traumatic brain injury, findings from Japanese nationwide survey. Brain tumors, neurosurgeons, 10 to 30% of seizures in the elderly, of course, more likely to occur with the low-grade, slowly growing primary tumors. Occasionally, in the elderly, we see it with metastatic metastasis in the brain. So this is important to know also. What's the treatment approach? Dr. Perucca mentioned about the AEDs, the anti-seizure medication. You can use any drug except ulixacimide because it's narrow spectrum AED. The seizures are mostly, of course, partial onset seizures. It's very rare to find primary generalized seizures. The good thing is the elderly population are more likely to respond to anti-seizure medication and the lower doses compared to the younger patients. And very important is to start low and titrate slow. So this is the basic principles. The special treatment, we have to look at the pharmacokinetics, the prevalence of hypoalbuminemia, the reduction of liver mass, the renal clearance issues, and the reduced absorption due to delayed gastric emptying, pH fluctuations. So this is very special to the elderly population. Professor Perucca also mentioned about the enzyme-inducing medications, the challenge, because most of the elderly patients are using multiple medications for comorbid conditions, whether it's psychotropic, chemotherapy, antibiotics, or warfarin. So this has to be taken into consideration in choosing the right anti-seizure medication to prescribe. The other issue is that the adverse effects of AEDs or anti-seizure medication, as you all know, is mostly you see it in the younger, with children with cognitive problems or delayed milestones, okay, and you see it in the elderly also. So this is the two arms where you see the cognitive behavior side effects are more pronounced. So elderly or senior citizens are definitely prone to cognitive and behavioral side effects, and you should choose the right medication and taking into consideration the comorbid diseases. And this is a long list of medication. Professor Perucca, I think he went through all the AEDs, just roughly looking at carbamazepine or oxcarbazepine, or this is, you have to look at, of course, at the sodium, the hyponatremia. You have to ask the patient if he's taking diuretics or antihypertensives, because the low sodium can cause problems. I think you can use whether first generation or second generation, depends on your experience, depending on the dose, and depending on how comfortable you feel with prescribing the AED. I'm sure, I think most of us have the experience of using different AEDs. And this is the usual issue, is whether you would prescribe AEDs, you look at the retention rate. And this is a study looking at, in the initial monotherapy of focal epilepsy in the elderly, 1-year retention rate for levetiracetam was higher compared to control-release carbamazepine and to better tolerability. However, the seizure freedom was the same. So whether you use first drug, first generation, second generation, third generation, you're looking at the retention because the seizure freedom rates are the same and nothing has changed over the past 30 years. And this is a famous study, 1 year follow-up, looking at T drugs, looking at the carbamazepine and the gabapentin and the lamotrigine and the equal numbers, and the seizure freedom was the same, and the tolerability, of course, was for lamotrigine was much better compared to gabapentin and carbamazepine. And I have to stress also about the dose of the anti-epileptic drugs that was not high. So we have to watch about the doses we give to the senior or elderly population. So lamotrigine and gabapentin were better tolerated than carbamazepine. Mechanism or underlying aging epilepsy, a lot of theories, the sodium-potassium pump, the production of free radicals, the oxidative stress, mitochondrial oxidative stress, and glutamate excitotoxicity. All are theories why elderly population gets seizures due to different etiologies like stroke, like Alzheimer's dementia, like traumatic brain injuries, and like brain tumors. There are vascular inflammatory metabolic factors also. All these mechanisms make it difficult to understand whether the association between epilepsy and aging is directly mediated by, or mediated by other clinical conditions sharing with epilepsy common pathophysiological abnormalities. So the conclusions is that the epilepsy in the elderly is an important and growing problem because of the increasing age of the population. I think memory clinics should be aware of this. People dealing with strokes should be aware of this. Neurosurgeons, even general practitioners. The clinical manifestations and causes are different from the younger patients. They mostly get the partial, the psychomotor, the behavior arrest with no auras, with no automatisms. So you have to be aware of the cognitive issues of the patient and the seizure semiology. Diagnosis is challenging because a lot of differential diagnosis, non-epileptic diagnosis. So you have to be wary about the diagnosis. The question is whether the aging brain is more prone to epilepsy. So this is one of the problems, but the other thing is that we know very well that medications do well in the elderly compared to the younger. So this is a bit conflicting. Status epileptics in the elderly is pretty serious with 50% mortality rate and probably related, of course, to the pathology. Natural history of epilepsy in the elderly is not well understood, and I have never seen a study on the natural history of epilepsy in the elderly. Understanding the mechanisms underlying epilepsy and stroke and neurodegenerative disease has to be addressed, and it needs further research. And thank you.
Thank you, Dr. Hassan, for this excellent presentation. We have a few questions from the audience.
Sure.
So, question, does typical absence seizure exist in elderly patients?
It's unresponsiveness. It's not the absence, of course, in children, and it's more of a it's emotionless stare, okay, and it's more of a confusion. But the problem is you don't find the automatisms, okay. So it's mainly a blank stare, okay. But definitely it's not like the absence you see in the younger children or adults, like the old term, what they call partial complex seizures or psychomotor seizures. Because the patients have other cognitive problems and they're not quite aware. So I think the caregiver usually notices that there is lapses of consciousness occasionally.
Do they have the 3 Hertz spike and wave discharges?
No, unfortunately, EEG, as we get older, the epileptiform discharges get less. So if you screen 100 patients with epilepsy in the elderly, I would assume, I mean a routine recording, which is a 30-minute recording. I think over 50% will turn out to be normal. And the abnormality usually on the EEG is not related to the epileptiform discharges. It's related to the pathology, whether it's post-traumatic, whether it's post-stroke. You can find slowing, but looking at spikes and sharp waves, I doubt it's easy. You won't find it easy.
Okay. So,
except if you do a prolonged recording, like 3 hours or 24 hours.
Okay. So another question, can we consider the electrical abnormalities as seizure in patients with Alzheimer's disease?
That's a difficult question. So you find the abnormalities you find are a bit different. And this paper I showed you addresses different patterns of electriform discharges, which could be a biomarker. But I'm not sure about how often we ask for prolonged EEG recordings for Alzheimer. But maybe if we do prolonged recordings of EEG, I know it's not that easy for an Alzheimer patient. We might pick up abnormalities more than the routine recordings, which is 30 minutes.
Okay. So there's a question in autoimmune encephalitis. So the question is, what are the precautions that needs to be taken with the use of anti-epileptic medications?
I mean, autoimmune epilepsy in the elderly?
In elderly, yes.
Usually, autoimmune process in the elderly is, I mean, we should search for malignancies, paraneoplastic. So this is, I mean, this patient has to be under a workup. It's different from the younger. So it needs a lot of a workup. And the first thing is you have to eliminate the possibility of paraneoplastic.
But the question, is there any precaution that we need to take in regards to anti-epileptic medications?
No, I think we should choose the anti-epileptic medications with no drug interaction. Whether he's on chemotherapy, whether he's taking medication, we have to choose the right one.
So other question is how we can differentiate between delirium, which is often a condition causing confusion for elderly patients, from that of seizure.
Yeah, that's an important question. I think you have to rely upon the history with the caregiver. He tells you there is lapses. He gets. You have to rule out possibilities of other metabolic conditions, which is very important. You have to the blood sugar, electrolytes, renal functions, and then I think the only way is you have to do the EEG, the prolonged EEG, and if you see lapses of changes in EEG consistent and compatible with change in behavior, you might diagnose a seizure.
Okay, and question, shall we treat acute symptomatic
seizures?
Yeah, so acute symptomatic single seizure. Shall we start them, or we'll consider it as similar as the young patients with solitary seizure?
No, I don't think so. If you do acute symptomatic seizures, whether in stroke, he has to be in the stroke unit or the ICU, intensive care, and he receives the anti-seizure medication, and maximum 1 week he's off medication. Okay? Because 1/3 of patients only develop epilepsy. But the other thing is important, most people who develop post-stroke epilepsy, for example, develop it within the first year. And this applies the same to post-traumatic epilepsy. Most patients who develop post-traumatic epilepsy, first 6 months to 1 year. But definitely there is no point of putting, I know there is a consensus among neurosurgeons, they always prescribe anti-seizure medication, whether it's traumatic or a brain tumor or anything. I think this is not valid. The only thing which I think is for brain tumors, if the patient the patient is presenting with a seizure and you discovered he has a brain tumor, okay, and this patient has to be on a lifelong treatment of anti-epileptic drug. This is the only case where you have, even if the tumor is removed, because the presentation was with a seizure. I mean, diagnosis came after a seizure. So this is the only condition you have to be on a long-term medical anti-seizure medication.
Okay, Dr. Hassan, so in just continuation with this question, so how is it different if the patient presents acutely at presentation with seizure and stroke and traumatic versus late presentation? So in terms of, do we need to continue anti-epileptic medications for both long-term
That's why
or
I
they are
didn't hear
different?
it. The patient
So,
presenting with acute symptomatic.
with acute symptomatic seizure, like in acute presentation with acute stroke,
Yeah.
or head injuries, acutely with seizure. So versus late. So how it will be differ the management in terms of long-term anti-seizure medication?
No, if the patient, usually if the patient presents with a seizure due to a stroke or due to a trauma, it's probably it's a big insult to the brain. Okay, so in other words, you can think of it in a different way. We all know that the post-stroke epilepsy or the post-traumatic epilepsy definitely is related to the severity of the brain injury, whether it's trauma or stroke or cortical involvement. So in such case, if he presents with an acute symptomatic seizure, you can argue that this patient might be put, because the risk of recurrence of a post-stroke or post-traumatic is quite high. So this is the only case where you can argue that you can keep the patient on anti-seizure medication. But if it's a mild traumatic or moderate traumatic brain injury, okay, it's unlikely that you will have an acute symptomatic seizure. And if it's a mild stroke and it does not involve the cortex, it's unlikely that you present with acute symptomatic seizure. Okay.
One question is, does lip smacking occur in patients, in elderly patients with seizure?
No, it's very rare. It occurs in the younger population.
Okay. And another question, in patients who had late onset seizure, do you recommend to start aspirin also with anticonvulsant?
Yes, based on the paper, I said, yeah, why not? Yeah, because there are, there is a paper looking at we all see MRIs with hyperintensities, and you don't make use out of it. You don't make hyperintensities with white matter changes, and the patient is just coming for reassurance. Maybe this population definitely would be put on aspirin, and if the patient has a seizure or presenting with epilepsy, I think it's wise to put him on aspirin. Why not?
Okay. And is the Vibrate safe in elderly to use for epilepsy?
There are no, any anti-seizure medication you can use, and because it's a broad spectrum anti-seizure medication. I know neurosurgeons love to prescribe Vibrate. I don't know in the rest of the region, neurosurgeons, but I think there's no problem. But the most important point is that you don't have to go to high doses. And maybe we can ask Professor Perucca if the value of blood level is of any importance in this population. I know Dr. Perucca doesn't believe in blood, he has a paper on blood levels. But what I'm saying is that there is no point of giving high doses of anti-epileptic drugs.
So maybe Dr. Perucca, if he wants to add anything?
Well, I agree with Hassan in general. I think drug levels can be of value, but they need to be interpreted very flexibly, and consider that elderly people tend to develop adverse effects and also to respond therapeutically at lower concentrations. So I agree fully.
Okay, so then there is another question for Dr. Hassan. So in elderly, so the status epileptic, is it more focal or general?
It depends. I have seen status epileptic. You have to, when you see status epilepticus, you have to rule out, of course, it's acute symptom. You can see diabetics with focused status epilepticus. It's very common. It's not rare. You can see brain tumors with focused status epilepticus. Okay, and then you can see, of course, generalized tonic-clonic seizures with status epilepticus. But focused status epileptic, you see it in this population, very common. Metabolic factors, brain insults, and sometimes it's quite hard to control. But you have to rule out a reversible, like a blood sugar or renal problems or whatever.
Okay, so there's a question about carbamazepine. So they use in an elderly patient, and the problem with conduction, cardiac conduction So is it safe and it's helpful in controlling the seizure?
About the heart?
Yes, about the heart.
Yeah, you're talking phenytoin, the same thing. I mean, we have other options. We don't need to use carbamazepine. If you're completely concerned about the heart, arrhythmias or conduction block, I think we have other options. Maybe Dr. Perucca can comment on this, about this issue of conduction block with sodium, like phenytoin and carbamazepine.
Actually, some time ago, we did a randomized study in the elderly with actually very sick people taking lots of medications. And we look at lots of cardiac, we did a lot of EKGs and a lot of cardiac monitoring, and we did not really come up with much toxicity. But we tended to use lower doses. And generally speaking, I agree with you. We have so many other drugs available these days, the carbamazepine, mainly because of its interactions, and also in some patients who may have indeed pre-existing conduction defects. We can use drugs which are safer at all levels, less interactions and less cardiac effects. Lacosamide would also be a drug I would use rather cautiously in this group for the same reasons.
Okay, so there's a question about embolic stroke. So it is known that it causes acute symptomatic seizure. Is it still the same recently during the current, the more recent data?
Yeah, embolic stroke presentation with the
embolic stroke, yeah, presenting as acute.
Because it touches the cortex. Yeah, yes.
Are there any updates about it with this regards?
No. The other thing, which sometimes it's not in the elderly, but in the younger population with the females, when they get the venous thrombosis, that's presenting with seizures, but it's an acute symptomatic seizure. And probably I have never seen a patient who was continued on medication because it's an acute symptomatic seizure. Usually you see it in females on contraceptive pills presenting with headache and a seizure. Cortical venous thrombosis.
Okay, so there is a question regarding the changes in Alzheimer and dementia. So what are the changes in epilepsy?
Generally speaking, there are normal variants in EEG in the elderly. You can find left temporal slowing, okay, in the normal person, in the normal individual, and this is accepted as normal. Okay, so this is the first thing we have to know: the slowing, the mind's intermittent slowing in elderly. This is normal. The paper I showed they showed sharp waves and epileptic discharges in selecting with patients with Alzheimer and patients with epilepsy and patients with Alzheimer without epilepsy. So this, I don't have the experience of monitoring patients with Alzheimer's as regarding EEG.
Okay, and a question, if you have seen epileptiform discharges on the EEG in an asymptomatic elderly, do you treat?
No, definitely no. Because what you see, it has to be interpreted or correlated with an ictal phenomenon to have a seizure. You find in children, you have a lot of discharges, okay, in migraine patients. They never develop seizures. So definitely we go by clinically, we don't go by EEG. And if you look at post-traumatic patients, if you look at EEGs of post-traumatic patients with no seizures, you will find sharp waves and you'll find spikes, and you will never have a seizure. So the epileptiform discharge, we say epileptiform discharge for one reason. It tells you, it reflects an injury to the brain. It doesn't reflect an epileptic phenomenon, and that's the difference. Okay.
Okay. So there is a question regarding hyperosmolar state of diabetes. Does it cause focal status? And if it does, how we can manage it?
Correct, hyperosmolar. I have seen it. It's very common. Focal status epileptics with diabetics.
Mm-hmm. And a question regarding, so which treatment that you will use for elderly in your clinical practice? And specifically...
Sorry, which?
which drugs that you use in a treatment, and the question whether Tegretol is better than the other AEDs in controlling the seizure.
I think it depends. You have a lot of options. You have to look at the comorbid condition. You have to look at tolerability, okay? Because the adverse effects in the elderly, sometimes it's very different from the younger adults. So the only thing, I make sure I don't give a high dose.
Okay. In terms of patients on dialysis, so which drug you would prefer to use, and when, whether before or after dialysis?
But this is mostly of a symptomatic seizure. I think we usually consult with the urologist, with the nephrologist, because sometimes the way they do this dialysis, it's an electrolyte imbalance. And if you do the EEG pre and post dialysis, you'll find the difference. So I think the best thing is that we have to discuss with the nephrologist about the dialysis, because they have certain, protocols they can change and the seizures won't come.
Okay, and there are actually two questions regarding regarding absence seizure. Maybe Dr. Hassan again,
Absence seizure.
Whether it appear in elderly or not.
The absence, it's a behavior. It's an altered mental status, abnormal behavior, but it's lacking. It's, of course, in epilepsy, it has an onset and offset. Okay. If you notice that the patient has an altered mental status, some behavioral changes, you can suspect it's a seizure. Not necessarily with auras or with automatisms like the semiology you see in the younger adults.
Okay, and the last question. So what do you think the best treatment in an elderly who had multiple comorbidities?
The first thing we have to look about the psychological state, the psychic state. If he's depressed, if he's anxious, if he's what, this is one of, you have to look at the AED, you have to look at the hepatic metabolism, you have to look at the renal, and then you choose the right medication. You have to look at the diuretics he's taking because of the hyponatremia if you decide to give a sodium channel like.
So in your clinical practice, which medication you use usually?
I always, for elderly, I try to avoid the anti-epileptic medications with the enzyme inducing for the elderly people. Except if it doesn't have any comorbidities, if it is not any medication, I might give him a small dose of sodium channel. Because sometimes you see patients in the elderly which they get a nocturnal seizure, and they never experience a diurnal seizure. And if you look at the seizure frequency of such people, they get once or twice a year. So I think in my practice, I always just give them one tablet at night, okay? And it works because you never know when is the second seizure coming. And this is what they call in clinical trials, probably Dr. Perucca, the pseudo placebo trials. This is a pseudo placebo, that's what I do.
So there's actually more questions are coming in. So there's one question about lacosamide used in elderly.
I think it's a great drug. Yeah.
So you can use it.
Yeah.
Okay. Then I think, and one question regarding the hyper and hypoglycemia, already we spoke about it. If you have an elderly patient with status due to hyper or hypoglycemia, what is the guideline to control seizure and maintenance, if any?
I think this is what we call an acute phase of status epilepticus. He has to be admitted in the neurointensive care and correction all the metabolic factors. And usually we give the benzodiazepines, they work very well during the acute stage. When you correct the metabolic disturbance, the seizures are gone.
Okay, and I think this is the last question. So thank you, Dr. Hassan and Dr. for the nice and informative presentation. I would like to, and thanks for the participant who joined us live. And just a few housekeeping comments. So you will get an evaluation form as soon as we exit this presentation. So please fill in the question, the evaluation. So, and let us know how we did in these webinars, so we can improve the webinars for the future ones. And also, all the recorded webinars, the lectures will be available at the ILAE website, so you can view them at your convenient time. So we will have our forthcoming webinar on September 25th. And from next webinar, so our webinars will be every fourth week, every fourth Friday at the same time with 2 speakers. And I hope that you had some benefits with these lectures, and we are welcoming all your feedback. And I wish you safety and good night. And I would like to thank all our speakers, Radha, for the moderation. And I will see you in the next webinar. Thank you very much.
Thank you.
Thank you, and bye, everyone.
Thank you.
Thank you. Bye-bye.
Bye.